right, so good afternoon, all. My name is Taiwo Amole. I'll be talking recently parent women in Kano, Northwest Nigeria. My presentation will follow this outline, and I'll start with the background. All over the world, women endure physical and psychological abuse from carers during delivery, and this is what is regarded as obstetric violence. And it occurs in institutions, whether they are public or private, as well as in other settings, such as in the home. It often manifests as denial of treatment, verbal humiliation, and disregard of the woman's needs or pain. For facility birth, that's institutional birth, there is a consensus actually that it discourages utilization of skilled care, that it prevents women from giving birth in the hospital. It causes dissatisfaction and reduces their confidence in the health system. It also reduces the desire for vaginal delivery and causes a lot of suffering. And it's actually regarded as a form of human rights violation for many women in many countries. In our setting, the traditional birth attendants conduct a lot of the home deliveries. And in Nigeria, maternal mortality has remained high, actually, despite several efforts to reduce it. And if we look at our national trend, from the Nigerian Demographic and Health Survey that was done in the last 2 decades, that's 2008, 2013, 2018, there were just mild fluctuations in the maternal mortality rates, but the difference was not significant. If you look at in 2008, maternal mortality was 545 per 100,000. And then in 2013, it was 576. In 2018, it was 556 per 100,000 live birth. And also in other indices, such as neonatal mortality, we've not had significant reduction, despite the fact that we have a lot of interventions targeted at reducing this. Most of these deaths are actually preventable, but there are a lot of social, geographical, and economic obstacles that these women face. And they may be responsible for why these indices have not improved significantly. And one of them is the quality of obstetric care that they receive. So when we have poor treatment, abuse, discrimination, and neglect while they are giving birth, particularly in the health facilities, it can cause increase in morbidity and mortality. Now, this is the definition of obstetric violence according to the law. It's the appropriation of a woman's body and reproductive processes by health personnel in the form of dehumanizing treatments, abusive medicalization, and it involves loss of the woman's autonomy and the capacity to freely make her own decision about her body or her sexuality. It's actually a form of human rights violation, and it's not been well investigated in many developing countries like ours. So that was why this study was done. This study assessed the forms and the burdens of violence experienced by women delivering delivering at homes and in the hospital, in our setting. And we felt that this would be the first step in developing interventions that can address this problem in northern Nigeria. A region actually that has very high morbidity, very high maternal mortality rates. So we determined the prevalence and the predictors of obstetric violence amongst women in Kano metropolis. Kano is one of the 36 states in Nigeria. It's in the northwestern part of the country. It has a projected population of over 2 million, 49% of which are women. As regards maternal health, about 65% of pregnant women actually receive skilled antenatal care, but in Kano, only 12% or 12.5% of them actually deliver in the hospital. We conducted this hospital in one of the largest hospitals in the state and even in the country. The state is, that's Kano State, is actually the second most populous in Nigeria. And the hospital where we conducted the study has a bed capacity of about 229, of which 53 of them are dedicated to delivery. And the nurses that care for these women are about, 2 to 11. That's the midwife patient ratio per shift. So you can have an idea of what the workload can be. So because the study was done we looked at the institution and we looked at the home setting. In the home setting, traditional birth attendants take most of the delivery, even though they are not formally recognized. A few of them have been trained by different health development partners, but not all of them are trained. And we looked at women who had delivered 6 weeks before the study. And we excluded women who had cesarean section or had stillbirth or unassisted birth. The sample size we calculated using the sample size formula for comparative studies, and we estimated 360 participants. That's 180 in the hospital for home deliveries and for hospital deliveries. And these women were recruited via the immunization clinic of the hospital. Okay, so for the hospital or the institutional delivery, we use the systematic sampling technique to select the women. And then for the home deliveries, because we had to go into the communities, we used a multi-stage sampling technique to select the women. And an adapted tool that was pre-tested was used to collect the data. We collected information on socio-demographic characteristics of the women, information on their last delivery, and on the prevalence and form of obstetric violence that they experienced. We analyzed our data using SPSS, and our outcome for this particular study was the experience of one form. So there are different forms. So the experience of at least one form of obstetric violence. And we determined, the factors that are associated with obstetric violence using the p-value of 0.5. But for the logistic regression analysis to determine the predictors, we used the p-value of 0.1. Most of the respondents responded to our study, and they were aged from 17 to 45 years with a mean of 26.9 plus or minus 5.72. Majority of them were Muslims, as the setting is, and the predominant tribe, Hausa Fulani, and about half had secondary education and were income earners. Almost all were multiparous with a mean parity of 4 plus or minus 2. And only 15% of them had complications during the last delivery. Complications included prolonged labor, retained placenta, postpartum hemorrhage, and breech delivery to perinatal. All right, for all the deliveries, about a third of them had experienced at least one form of obstetric violence. That's about 32.2. And then for the hospital delivery, that's overall, when we combine both hospital and home deliveries, about a third of them had experienced obstetric violence. When we compared hospital deliveries and home deliveries, obstetric violence was significantly higher amongst those who had hospital deliveries. It was almost half of them, 48.6, whereas for home deliveries, only about 16% of them had obstetric violence. So these are the different forms of the violence that we examined, looking at the physical abuse, verbal abuse, failure to meet professional standard of care, and poor rapport between the woman and the provider. And failure to meet professional standard of care was actually the highest. Most of the women reported that. About 2/3 of the women reported that in different forms, whether neglect and abandonment during delivery, or refusal to provide pain relief, or augmentation of labor without consent, or episiotomy without consent. So that was the highest form of obstetric violence. So other forms that have been reported in other studies were not reported here, like the sexual abuse, stigma, discrimination, blood transfusion without consent, and disclosure without consent. They were not reported at all. When we looked at the factors that were significantly associated with obstetric violence, we noted that the level of education was significantly associated with obstetric violence. Those women who had formal education reported, more of them reported that they had experienced obstetric violence as compared to those who had no formal education. All the other socio-demographic characteristics like their age, their tribe, religion, were not significantly associated with obstetric violence. And then when we looked at their parity also, parity was significantly associated with obstetric violence. We saw that those who were giving birth for the first time reported obstetric violence much more than those who were multiparous. And then the place of delivery also was significantly associated with obstetric violence. Those who delivered in the hospital experienced it more. And those who experienced complications during delivery also experienced obstetric violence more than those who did not have complications during delivery. I've mentioned some of the complications that they experienced during delivery. Okay, so I think I've said many of these when the table came up, that those who, when we then compare hospital versus home delivery, as in looking at the factors responsible for obstetric violence and amongst those who delivered in the hospital and those who delivered at home, we found out that those who delivered in the hospital, their ethnicity was significantly associated with obstetric violence. Those who were non-indigents, those who were non-Hausa Fulani, actually experienced obstetric violence more. And then those who were, giving birth for the first time, the nulliparous, experienced it more. Whereas for those who gave birth at home, only parity was associated with obstetric violence. When we looked at the predictors of obstetric violence, that's those factors ab initio that were reported in literature to be associated with obstetric violence, and then our own factors that had a p-value of 0.1 or less. When we put those factors into the logistic regression model, the predictors of obstetric violence remained parity. Those who were giving birth for the first time were about 3 times more likely to experience obstetric violence. So also those who gave birth in the hospital were more than 3 times likely to experience obstetric violence. And those who had complications during labor and delivery were about twice more likely to experience obstetric violence. So we noted that obstetric violence was prevalent in our setting, and that women who delivered in the hospital setting were more likely to experience it than those who delivered at home. And we felt that this could actually be a contributor to the persistence of underutilization of skilled birth attendants. I gave the figure at the beginning that a lot of them, about 2/3, actually attend antenatal, but only about 1 in 10 of them deliver in the hospital. And we know that in settings where maternal mortality has been reduced, attendance of skilled birth attendant, having a skilled birth attendant at delivery is key to reducing maternal morbidity and mortality. So the other thing that we noted from our study, and which we thought would be for future research also, was that the setting at home where the traditional birth attendants take delivery was not ideal to describe some forms of the obstetric violence, particularly in the domain of failure to meet professional standard of care. For example, not giving consent, physical examination or vaginal examination, episiotomy, and augmentation of labor were not practiced at home. So the home setting was not ideal to describe them, as the TBAs were reported to just observe the delivery naturally and to guide the woman, cut the cord, and clean up after delivery. So our recommendations were that to refine the quality of obstetric care, modifiable predictors of obstetric violence, like the place of delivery and the quality of care that is given to these women, will need to be looked at. We also thought that we need to do future research, particularly qualitative research, to understand obstetric violence, particularly in home settings and how it is affected by social factors. And look at other perpetrators of obstetric violence. There's need to explore beyond TBAs as delivery service providers in the setting of OV, okay? And we need to look at other individuals that may serve as providers at home. healthcare workers definitely require training on respectful maternity, and we need to be able to gain insight into what happens at home to be able to understand obstetric violence better. So we concluded that obstetric violence is prevalent in our setting, and more educated women, primiparas, women who delivered in the hospital, and those with complications were more likely to experience obstetric violence during childbirth. Women who deliver in the hospital would actually need a lot of support from all stakeholders so that they can have a dignifying process of childbirth. And healthcare providers and researchers will need to be trained. They will need to be involved in future research so that all the evidences acquired can be used to develop some technical guidance for healthcare providers and the government, so that we may have, this may accumulate in policies or laws that can protect women and support them during childbirth. This brings us to the end of my presentation. Thank you very much for listening.